Hi, this is a lecture on chapter 47 that is just covering the anatomy and function of the neural system. And most of this should be a review for all of you, but I do want you to understand the major concepts, so we're going to go through the things that you absolutely for sure should know, okay? We're looking at the neurological system. And the neurological system has two main parts. One is the central nervous system, the other is the peripheral nervous system. The central nervous system is made up of the brain, the spinal cord, and we might also add that we know there's cerebral spinal fluid that is circulating throughout the brain and spinal cord. We also have the peripheral nervous system, which includes the autonomic nervous system. Remember, the autonomic nervous system we've discussed quite a bit in pharmacology, and the autonomic nervous system is made up of the sympathetic and parasympathetic side. Be sure you review that and make sure that you understand the difference between the effect of parasympathetic stimulation versus sympathetic stimulation. We also have motor nerves, and we can have voluntary movement because we have these motor nerves. We also have reflexes built into that, and sensory. Another word for sensory might be somatic, and you should remember that when we were studying about pain, and it is picked up by somatic receptors. We have pairs of spinal nerves that come from different parts of the vertebrae. You don't need to remember how many pairs, but I do want you to recognize that they come from these areas. The first area is from the cervical vertebrae. And you have 8 pairs of spinal nerves that come from there. The second area is the thoracic vertebrae, which has the most spinal nerves, and there are 12 that come from the thoracic area. The lumbar spine has 5 pairs of spinal nerves. Sacral has 5. And then we also have the coccyx, which has one pair of spinal nerves. The brain is really interesting. We're going to be looking at it in a fairly beginner standpoint, very foundational kind of understanding of the brain. Some people, as you may well know, they can get a bachelor's degree really in neurobiology. There's so much to learn and understand about the brain, and it does seem like we are progressing in our knowledge fairly quickly. We know more and more as time goes on. So anyway, basically, you do want to understand that the brain has these components, and the first thing we want to talk about is the meninges, and there are 3 layers of meninges. So these are coverings that cover the brain. Sometimes, by the way, people have various injuries and bleeds into the space in between these layers. Also problems with infection, so it's important to understand we have 3 different layers. The ventricles are 4 basically cavities. You can think of them as cavities that are going to be containing cerebral spinal fluid, and the ventricles sometimes can actually cause some kinds of pressure and what we would say herniation if there's too much pressure from cerebral spinal fluid within the ventricles. it can expand and herniate, and in other words, move into other areas of the brain. Why is it important to understand these different areas is really because for a nurse, it's going to relate to what kinds of deficits you're finding in your patients who have some kind of neurological injury, either from a stroke, from trauma, can be very likely. All right, so tumors, and in our next chapter we'll be looking at various disorders of the brain. So first, it's a good idea for us to understand the function of different areas of the brain. Cerebral spinal fluid actually takes nutrients and is extremely important for bathing the nervous system. High pressures in the cerebral spinal fluid are going to really cause damage, and so we do have patients who have something like increased intracranial pressure, and sometimes we actually, you'll find nurses and intensive care nurses working to actually drain off some cerebral spinal fluid to decrease the damage from the pressure. The brain stem is extremely important for life functions, and we need to understand that it is possible, say, come over here, and it's possible for someone to have an injury that affects all of this, but if the brainstem is intact, you may well have a person who's not alert in any way, not responsive in any way, but they still have, let's say, respiratory function, okay? So very, very important for us, especially when we begin to think about what's happening for our patients that are in vegetative states. All right, they may have a perfectly intact functioning brain stem. The cerebellum, you can see the diencephalon, often you can think of as, let's see, it is over here, it is separating one half of the brain from the other in the cerebral cortex, and the cerebrum, where pretty much our personality, our thoughts, our judgment, that type of thing is in the cerebrum. So damage to the cerebrum is going to definitely change a person's ability to think, sometimes understand language, their judgment, the meaning they put to the sensory information that they have. All right, so where the damage is, for whatever reason, is going to tell us a bit about what kind of functional deficits our patients are going to have. The cranial nerves emerge from the brain. We have 12 pairs of cranial nerves. They have various functions. I'm not going to ask you to memorize it, but I want you to understand this because you're going to be reading history and physicals. Those of you that go on to further your nursing education, there may be a time when you're asked to memorize the function of the different cranial nerves. They do come in pairs. They do emerge from the brain. Nurse practitioners, physicians, our physician's assistants, when they are giving a full physical exam, they are always testing for the function of the 12 cranial nerves. And here is a picture for you, a little bit of a diagram to give you a better understanding. You might just take a few minutes, look at this. The first cranial nerve is dealing with the olfactory sense. As I say, there are 12, and the 8th, vestibular, and that's part of the inner ear. How we kind of understand where we are in space is affected by this 8th cranial nerve. We have facial motor nerve, cranial nerve 7, All right. I'm not going to go through each one, but I want you to see. All right. Trigeminal, which we hear about sometimes, is the fifth cranial nerve. It has a sensory and a motor function. Sensory for the face, sinuses, teeth, controls the muscles of mastication, right, when you're chewing, for instance. Just take a little bit of time, look through here, recognize that some have sensory and motor, some have simply motor. There's cranial nerves that affect only a sensory, like the olfactory nerve that affects the sense of smell. Those of you that would go on into a BSN program, you more than likely are going to be asked to memorize all 12 cranial nerves and what their function is. And when you are doing full assessments, you can be asked sometimes to know how you would assess for each one of these cranial nerves. The cerebrum, remember we talked about the area of the brain that is the cerebrum, and it's at the top, the front, the sides, and this is divided up further into lobes. So you have the frontal, temporal, parietal, occipital lobes. And if you take a look at the diagram I have here for you, you can see the functions, the main functions of each one of these different lobes. So for instance, someone who has frontal damage, right? We can have people who have had trauma, for instance. You might sometimes even think about your football player who's being hit on the head repeatedly and can wind up with problems in this frontal area. It doesn't have to be a football player, of course. It's just one example. It can be from problems with a bleed, from a cerebral vascular accident. People can have problems from a cerebral vascular accident where it's related to emboli, thrombus, some kind of clot that has decreased the oxygen and nutrients to certain parts of the brain. The reason for the damage at this point for our understanding of things is we're just looking at what areas have what function, and then later when we start looking at different disorders, we'll recognize that if someone has damage in a particular area, we would expect that they might have some deficits in this kind of function. So frontal lobes are extremely important. They have a lot to do with planning and our execution of a task so that we sequence things in the right order. The decisions we make come from the frontal lobe, where the brain is gathering information from various sources and choosing, let's say, even the best response, what would be the most effective response for them. Motivation is within the frontal lobe. So the types of things that motivate us to get up off the couch and do something, right? Our affect, and affect we can think of as our expression of an emotion. So someone who has had damage to this area may have problems in those areas in their behavior. The temporal lobes are really interesting, and I think of them for the most part as auditory and language. And so your patient who's having problems with receptive or expressive language, many of our neurologically injured patients, that's exactly the kinds of problems, right? You think about the patients you've taken care of who have had a CVA, for instance, and they may not understand a direction that we're giving them, or they may not be using appropriate words when they're talking to us. They may not be able to speak to us using normal language. All of those functions are centered in the temporal lobes. The parietal really has to do a lot sometimes with our sense of time, our sense of space, the relationship of one thing to another. Okay, so again, if there were to be some kind of injury from disease or trauma, those types of mental functions will be affected if the parietal lobe is affected. And occipital is dealing with vision, so we're not looking too much at this point in time in terms of how the eye works, but the occipital portion of the brain is the portion that actually makes sense of what our eye is seeing. So it will put things in context. It can sometimes, if there's injury, you may have people that only see to the right side, or people that only see to the left side. All right. All these different areas and their functions can be affected according to the kind of disease or traumatic injury your patients may have. This is a critical thinking that is in your book. And if I remember right, I don't think your book has exactly the right answer. So let's go over it. A client receives albuterol treatments for her chronic COPD, her chronic obstructive pulmonary disease. You may remember from pharmacology and your giving meds at your clinical site that albuterol is in a classification of being a bronchodilator. So let's just stop right there and think, if a drug is a bronchodilator, then what part of the autonomic nervous system is probably being affected by the drug? Albuterol is what we might call a sympathomimetic drug. It's a drug that mimics, or you could say stimulates, the sympathetic side of the nervous system. And we should know the sympathetic side of the nervous system dilates the bronchial tubes. So a client's receiving albuterol, it's going to dilate the bronchial tubes, and we do get a certain effect. And as we go further into looking at your critical thinking problem, it says the medication opens her airways effectively. We would expect that it would. But after her treatments, she often reports that her heart is racing. And so what part of the autonomic nervous system do you think this medication affects? Again, I'm pretty sure I believe that your textbook is not telling you the right answer. The part of the autonomic nervous system that it affects is going to be the sympathetic side, because what does the sympathetic side do? You should have memorized by now, the sympathetic side of the autonomic nervous system is going to bronchodilate. Remember, this is your fight or flight mechanism, and it's going to bronchodilate, and it's also going to increase heart rate. So you're going to have patients that sometimes have problems with tachycardia, meaning a heart rate over 100. Once you've given them a sympathomimetic medication like albuterol, a very, very common bronchodilator that we give patients. Another thing we want to really look at is what happens to the aging nervous system. Many of the patients that we care for as nurses are 65 years or older. And your generation of nurses will experience that even more than my generation has. And I would still say the majority of my patients in intensive care, certainly not all of them, but the majority of them have been older patients. And so let's take a look and see what could we expect to happen for someone who is aging, and how is that affecting their nervous system. So a decreased blood flow to the brain could definitely be beginning to happen for that person, and some people have more or less problems with this. With decreased blood flow to the brain, we're going to have decreased mental function. The thinking may be a little bit more fuzzy, maybe a little bit slower. They may not pick up on subtleties as quickly as they would have before. And we also can have an increase in what we would call fainting. And if you haven't learned it by now, make absolutely sure you know that when we say syncope, we're talking about fainting, okay? Along with that, of course, if we have a problem with decreased blood flow to the brain and the patient has some problems with syncope, the nurse right away should be thinking, now we have a patient that has a safety problem, right? The patient may fall. The patient may not be able to stand up as quickly and walk to somewhere that they, in a way that they normally would. Okay, and so it begins to contribute to a safety problem for our elderly patients. The other thing is that they can have aging pigments in the nerve cell, deposits of aging pigments in the nerve cell. So this really might well affect reasoning, judgment, orientation, these cognitive kinds of skills. Now that doesn't mean everybody has problems with this. But it is an explanation for our aging patients who do have some problems, okay? We can have many people in their 90s who still have very good cognitive skills, although chances are it might not be quite as sharp as it was when they were younger, all right? Another thing is most of us have learned that there are changes in sleep patterns for our elderly patient. As people age, they tend to not get as much sleep during the night. They tend to wake up more often during the night. Sometimes it's because they simply need to empty their bladder, but there can be other reasons for that change in sleep pattern, and decreased norepinephrine is the reason for that. So as someone ages, they have less norepinephrine. They may wake up at earlier times. I don't know, but I look forward to sleeping in when I'm retired. Kind of works against it to recognize that there might be, due to decreased norepinephrine, maybe I'll wake up a little bit earlier instead of being able to sleep in. Who knows? But you want to understand the change in sleep patterns can be a normal effect of aging, this decreased norepinephrine. And norepinephrine is a neurotransmitter, as you know. Okay. The Glasgow Coma Scale is something that we taught you at the very beginning, first week or two of our skills labs when we were teaching you how to do a full assessment. So the Glasgow Coma Scale is an international scale. It is used to assess a patient's level of consciousness, how awake, alert, how conscious is that patient, and everything being normal and the patient being fine. The Glasgow's Coma Scale is going to give that patient a score of 15. Nurses use this all the time in patients that have had some kind of neurological injury and a decrease in consciousness, or there's a potential for it. So, you may have nurses who are in an intensive care unit, and they are doing these checks every 15 minutes when someone first comes in after they have had some kind of head injury. But remember, you should be held accountable for it, to remember that the total possible score is 15. We ask you, when you go to your clinical sites in our LVN program, to check these things when you're doing a full assessment on your patient. We ask you to do a full assessment on every patient, and we ask you to check where that patient fits on the Glasgow Coma Scale. Now, we're asking you to do that on every patient so that you get used to doing it and you have well memorized how you're going to do it when you need to, and that you can recognize a change in level of consciousness and that is significant change for that person. In reality, nurses are not doing Glasgow Coma Scale checks on every patient that they encounter. They're doing them on patients that have already had lower levels of consciousness, already had some neurological problems, or patients that are needing to be monitored for a change. We'll go over the 3 areas in the Glasgow Coma scale that a nurse monitors. And the first one is eye opening. The 3 areas really are eye opening, best motor response, best verbal. So if we're going to look at eye opening, we're looking at the patient's eye opening and what causes that patient to open their eyes. If they open their eyes in a spontaneous way, the same as you and I would, we give them 4 points. If that patient will only open their eyes in response to a verbal stimulus, for instance, you come into the room and you call that patient's name, or you start talking to that patient and they open their eyes because they hear you talking to them, they're responding to a verbal stimulus, and you would give them a score of 3. If you have a patient who opens their eyes only to pain, that gives that patient a score of 2. And in that case, then the nurses are going to have to provide some kind of painful stimulus in order for that patient to open their eyes, all right? And they're checking, is that patient going to open their eyes in response to pain? So sometimes what we might do is take that patient's nail bed. I'm just using my finger right now. Sometimes we can even put a pin on there, but you press down, put pressure on that patient's nail bed, and if that pain, and try it on yourself, it's going to hurt. If that pain causes the patient to open their eyes, then you would say they open their eyes to painful stimulus and not to other kinds of stimulation. Sometimes we might pinch a little bit on the forearm. Sometimes we might do, which is not recommended to do a lot anymore, but it is still being done, and do what we might call a sternal rub, so that we ball up our fists like this. Can you see? Yeah, okay. And we take those knuckles and we rub right down the middle here on that patient's sternum. It hurts. And if that's what causes them to I won't say wake up, but open their eyes, they get 2 points for that, okay? Always these points are the best response we can get, all right? No response, and there are patients who just do not open their eyes. They are comatose enough, they will not open their eyes. We give them a score of 1. Perhaps I should back up just a little bit and explain that it may not be the way that the general public thinks about it. Someone either is in a coma or they're not, they're not in a coma. There are levels of coma. So some people are in very deep comas, and some people are in a fairly light coma. All right, so that's part of what this Glasgow coma scale is going to tell us when we get down to totaling up all the points we would give that patient. If we're looking at what is the best verbal response, then now we're looking at how is the patient communicating verbally. So if it's just a normal conversation like you and I would have, and you don't notice that there's any kind of a problem, you give that patient a score of 5. However, if the conversation is a bit confused, maybe they are having real memory problems, maybe it's a bit nonsensical what they're telling you, then you're going to give them a score of 4. If they use inappropriate words, now we're not just talking about what's socially appropriate and what's not socially appropriate. We're also really talking about, are they using the correct word for the meaning that the patient's trying to get across? So if the patient is calling a pencil a car, if they're using other words that don't have the generally accepted meaning for that word, then we would say they're using inappropriate words, okay? And we give them a score of 3. Incomprehensible sounds, meaning the patient can verbalize, but the patient is not putting words together, not actually saying words. They're just making sounds, a bit like we might think that infant, toddler, sometimes we would say they're babbling, right? They're just kind of making noises and sounds, but there's nothing comprehensible about the sound that they're making. Ba ba la la, da da boo doo doo la la. They're making sounds, but they're incomprehensible sounds. So that's a score of 2. And then if they have no verbal response whatsoever, then we're going to give them a score of 1 point. Okay, and then the third thing we look at is the motor response. If you remember, we've taught you when you're doing your neurological assessment, you're going to assess, does that patient respond to command? Respond to direction? So in other words, if you ask them to raise their arm, they're going to raise their arm. If you ask them to grip your finger, they're going to grip your finger. All right. Anything that you might ask them to do, will they have a motor response to that command that you just gave them? If they do, then you've got a score of 6 that you're going to give them. Now, there are patients who are in a level of coma, and they're not in any way going to obey a command in terms of following a direction. However, they may have some movement and localizing pain. So if you are pinching that patient on the forearm, you may see some kind of movement in that area. And we would say in that case they're localizing pain. All right, and we give them a score of 5. Now, someone that actually withdraws from pain, in other words, pulls away from you when you hurt them. So again, maybe you're pressing on the nail bed and they pull away. That's their response. Withdrawing from the pain, then that gives them a score of 4. Abnormal flexion is 3. Abnormal extension is 2. And when we look at this, I do want you to carry this thought on over to the fact that your textbook is showing you pictures of decorticate posturing and decerebrate posturing. And they can fit into one or the other of these categories. So if you have abnormal flexion, I'm trying to fix this, so if you want to take a look at me, you can. You've got a patient who, let's just look at the upper extremities at this point. They're moving in. Maybe he's doing something like this, okay? If that is the posturing of your patient, then we're going to say is decorticate. If, on the other hand, it looks more like this with the upper extremities, take a look at your picture. Just looking at me may not get the point across totally. Then you could say he has decerebrate posturing. Decorticate or decerebrate posturing are very poor indicators of your patient's neurological status. If the patient has no motor response at all, then we would give them a score of 1. Okay, those are the main things you need to know. It's not a lot, it's not in a lot of detail, but it should help you get through the rest of our chapters as we look at patients that have some neurological disorders. Thank you.